Good morning, everyone. I am Dr. Yoshita Batish, a junior resident from the Department of Radiodiagnosis at MMI MSR, Ambala, Haryana, and I'm going to present a paper on the topic Disseminated Neurocysticercosis. Human cysticercosis is important cause of epilepsy and neurological morbidity in many developing countries. Cysticercosis is caused by the Cysticercus cellulose, a larval stage of the tapeworm Tinea solium. The commonest form is neurocysticercosis. Cysts occur especially in the striated muscles, subcutaneous tissue, the nervous system, and the eye. Cysticercosis becomes symptomatic almost exclusively in the nervous system and the eye. Going to the materials and methods, this study was a cross-sectional study conducted in the Department of Radiodiagnosis in MMI MSR Haryana from 1st April to 15th August 2025. Scans were performed on Siemens Somatome Definition Flash 128 slice CT scanner and United Imaging for the MRI scans in the Department of Radiodiagnosis of MMI MSR. We had few patients. The first patient was a 35-year-old patient presented with one episode of convulsion and altered sensorium, and there was history of pork intake occasionally. So we performed a CT brain sections NCCT scan for this patient, which showed multiple subcentimetric lesions with eccentric calcific foci suggestive of scoliosis, noted scattered diffusely in the bilateral cerebral and cerebellar hemispheres, including the gangliocapsular region, ventricular system, and recti muscles of the eye, scalp, and all the paravertebral neck muscles and posterior one-third of the tongue. Here we could see the NCT section, axial section of the brain, which showed cysts with scoliosis scattered diffusely in the bilateral cerebral hemispheres, cerebellar hemispheres, cysts in the ventricular system, then cysts in the medial rectus muscle of the eye, then in the posterior paravertebral muscles of the neck. Here also we can see the cysts with scoliosis in the medial rectus muscle of the left eye, and cysts is seen in the paravertebral neck muscles. We performed the MRI brain plane plus contrast MRI section for this patient, which showed numerous hypo to isointense lesions on the FLAIR images in the ventricular system and in the scalp region, then also in the medial rectus of the left eye and in the gangliothalamic region, and on T2 weighted images it showed hyperintense lesions. Here also we can see hyperintense lesions in the posterior paravertebral muscles of the neck, then in the scalp region, then in the medial rectus muscle of the eye, and here the T1 weighted image shows hypo to isointense lesions in the ventricular system. MRI shows multiple thick walled cystic lesions noted in both cerebral and cerebellar hemispheres, including bilateral gangliothalamic region and bilateral lateral ventricles, which appear hyperintense on T2 weighted imaging, hypointense on T1 weighted imaging and FLAIR imaging, and shows diffusion restriction on diffusion weighted imaging, and no blooming is seen on GRE. The lesions show peripheral ring enhancement on post-contrast study with central non-enhancing component. Similar morphological lesions were noted in the scalp region, both orbits, inferior temporal fossae, tongue, and neck muscles. So the diagnosis was disseminated cysticercosis. Neurocysticercosis is the most common parasitic infection of the brain and leading cause of epilepsy in the developing world. The major forms of neurocysticercosis are parenchymal, ventricular, and subarachnoid, spinal, and orbital. Ventricular and basal cisternal locations are considered to be malignant forms as the mortality rate is high when hydrocephalus is present. Extensive involvement of the brain, eyes, muscle, spinal cord, and subcutaneous tissues is rare. Extraocular cyst resembles a slow-growing tumor with focal inflammation. Our patient had cysts in the rectus muscles, but did not have any ocular complications. Cysts in muscles may manifest as muscular pain, weakness, or pseudohypertrophy. Subcutaneous cysticercosis is frequently asymptomatic but may manifest as palpable nodules. MRI considered the best neuroimaging tool for radiological diagnosis of neurocysticercosis, with advantage of being able to differentiate the stage of the parasite as well. So the stages of neurocysticercosis, there are 4 stages. First is the vesicular stage, where there is no surrounding edema and no enhancement. MR shows that the cyst is isointense with the CSF. The scolex is discrete, nodular, and hyperintense. which giving a target appearance. Enhancement is typically absent. Colloidal stage, cyst is hyperdense to the CSF on NCCT scan and demonstrates ring enhancing capsule on contrast enhanced CT scans. MR shows that the cyst is hyperintense to the CSF on T1 weighted imaging, and that scolex appears hyperintense on flare with surrounding edema. Enhancement of the cyst wall is typical. In the third stage or the granular stage, mild residual edema with enhancing nodule is present. Nodular or faint ring-like enhancement is typical. Nodular calcified stage, which is the last stage of neurocysticercosis, it shows calcified nodule without surrounding edema. Calcified lesions are typically seen as hypointensities on T1 or T2 weighted imaging and blue when showing blooming on GRE images. Management of neurocysticercosis includes antiparasitic drugs like albendazole and praziquantel, anti-seizure prophylaxis, and symptomatic medications. These are my references. Thank you.